Episode 75, The Paradox.
Welcome to The Paradox with your attending, Dr. Eric Larson. He is a practicing anesthesiologist and clinical assistant professor at Michigan State University College of Human Medicine. Listen in as he takes you behind the scenes of what practicing medicine in today's ever-changing world is like with another doctor. The Paradox is a fun and accidentally informative show for physicians, patients, or anyone who has ever found themselves in a waiting room.
Welcome to The Paradox. I'm your host, Dr. Eric Larson. Thank you for joining me as we explore the U.S. medical system in a fun and informative format through expert analysis. Today's expert is David Leonard, Chief Legal Officer for the Spectrum Health System. Spectrum Health is the medical system where I do most of my work in anesthesia. It's also based primarily in Grand Rapids, however it is in many locations in West Michigan, and only because I got in trouble with this many years ago when I was in the Upper Peninsula. If you're familiar with Michigan, there's both a Lower Peninsula and an Upper Peninsula. The Upper Peninsula, when you refer to West Michigan, of course, you're talking about Iron Mountain, and that's the on the Wisconsin border. So when I speak in West Michigan, I mean very loosely in the Lower Peninsula, which is west of Lansing and on the Lake Michigan lakeshore. But anyway, David is a good friend and someone with intimate knowledge of how a health system operates, from legal machinations, and the things that no one ever talks about, and I think are interesting. And if you have any sort of curiosity about how a hospital works, just the nuts and bolts, this is a great episode, and it's going to be fairly brief in the sense that it's in just one show. We're going to cover kind of everything as far as credentialing, the governance. For instance, when you walk in the hospital, who's the boss and how do things get done? How are the processes existing, and how you go through the check-in process for, say, surgery, or if you're coming out of the emergency room? How do the CT scanners get there? How is the laboratory organized? How do phlebotomists show up? Those sorts of nuts and bolts no one really knows. You don't really think about it. And just like going to any other store or any sort of business, for the most part, as a customer, you don't really care. You just want to get whatever product or service they provide. But as so often the case in medicine, it's important to kind of know how things on the basic structure operate, because that then helps you diagnose the problems and certainly solutions for what ails our healthcare system. So today we're just going to talk about the hospital and how it runs. And then we're going to talk about sort of what got me into thinking about this to begin with. When it comes to the accreditation process, which is essentially who's allowed to work in the hospital and get granted privileges for performing surgery or taking care of a patient with a heart attack or whatever it might be. How do you have people get in and practice for long periods of time, or maybe perhaps even in multiple hospitals, who are causing lots of harm? And the great example of this is the doctor known as Dr. Death in Texas, Dr. Christopher Dunch, where he was operating and causing all kinds of harm, damage, pain and suffering at multiple hospitals. And it took sort of heroic efforts for people to stop him from doing this. And so what sort of safeguards are in hospitals? Is it different now than it was back then? And I think that we talk about that a little bit too. But how does that happen, and how are they prevented, and how do hospitals and certainly colleagues, other physicians in the hospital, how do they protect each other from people who are causing harm, and how do they stop them if they're harming their patients? So we talk about all that. Again, show notes page will be at theparadox.com/075. There'll be a few things on there that you can reference. I would encourage you to go to iTunes right now, or whatever podcast player you're using. Please leave a written rating. 5 stars is always encouraged. And if you're so interested, it is New Year, so you're welcome to go to patreon.com/theparadox. And there you can contribute to the show and become a patron supporter and help support this enterprise. But without further ado, David Leonard, Chief Legal Officer at Spectrum Health System, on how hospitals work. Enjoy. Welcome. I'm delighted to have my good friend here, David Leonard, who's the Chief Legal Officer at Spectrum Health System in Grand Rapids, Michigan. David, thank you so much for joining the Paradox today.
My pleasure. I'm happy to be another type of doc with you. I really like the Paradox theme, so I don't have an MD, but I do have a JD, so I think I qualify.
You do, absolutely. You're actually the second JD I've had on. So actually, I think I've had a couple JDs. Some of them are also MDs, but as long as you have the D in there somewhere, we'll get a pass. And for what people are paying for the show, I think it's just fine. let's start off with a little bit of background about you. And you're an attorney, obviously, at Spectrum Health, which is, for those who are not familiar, which I would expect you to be, it's Grand Rapids hospital system, nonprofit hospital system. And tell us a little bit of your journey about how you ended up at a hospital from law school.
Sure, happy to. And I would just point out to the audience that Spectrum Health System, although based in Grand Rapids, is actually more of a holistic health system comprised of approximately 15 hospitals. We employ 1,500 physicians and advanced practice providers, APPs, and have one of the nation's most renowned, most successful health plans called Priority Health, where we insure almost 900,000 people around the state of Michigan and in 48 states around the country. So we're really more of a health system, consider ourselves more of a health company, and very much interested in keeping people healthy rather than just treating them when they become sick. And I have the privilege of serving as Chief Legal Officer at Spectrum Health, where I'm responsible for legal services, as you would assume, but also risk management and government affairs, and also work very closely with our corporate compliance function. As you know, from being a physician, we are hyper-regulated in healthcare,
Yes.
and we have no shortage of interesting days in legal risk compliance and government affairs at Spectrum Health. I started my legal career in Indianapolis, Indiana, where I grew up. I had a grade school teacher named Teddy Carnegas who told me that I argued with her so much that I should become an attorney. And that stuck with me, and I kept arguing. Went to law school at Indiana University, also undergrad at IU, and practiced with a health law firm in Indianapolis. I was an associate for 5 years and a partner for 3 years called Hall, Render, Killian, Heath, and Lyman, where I learned a lot about serving hospitals and physicians in structuring how they provide services to their patients. And then in 2002, late 2001, early 2002, got a call that Spectrum Health System was seeking its first general counsel. And I've served effectively in that role now for almost 18 years. It's really very interesting to see what state and federal government throws our way as far as regulation. And most of the time I find that it's the bad apples that cause the rest of us to have to jump through so many hoops.
Yeah, sure. I mean, that's probably the case for most laws that are written in general, right? It's the one person does something terrible, and then you pass a general law that kind of affects everyone, and it's not oftentimes helpful, and it's a hindrance oftentimes to getting the work done that you were doing fine anyway without, most people don't need to have a regulation saying you're not allowed to put poison in food, yet we still have those regulations, right? So I wanted to talk to you today about something that most people probably know nothing about. In fact, I would argue most people who work within the hospital system really don't know much about either, which would be the governance of a hospital. Like, how does it even run? Because I think most people look at a hospital as you walk in and you get care, and then you walk out. Then you receive bills from a number of different services. Initially, and I think that's part of the progression for you when you entered Spectrum Health, because Spectrum Health has changed significantly, as healthcare has over the last 20 years or so. There was a merger for different hospitals, which was before you came on, but
that was in 1997,
right,
about 5 years before I arrived. Correct.
And then since then, the hospital system has grown significantly. Other hospitals have been included. You've medical groups, you've had insurance companies, and all this sort of integrated care sort of model has been sort of put together, very similar to anywhere else in the country. I think there are a lot of these sorts of systems in other cities.
And a lot of that is driven by the hyper-regulation and by the expense of electronic health records. So it's so very expensive to run a healthcare enterprise today because it's so highly regulated, and because the government requires you to have an electronic health record.
Right.
And so many smaller hospitals and smaller physician groups really can't afford to do that effectively alone. And that's really fueled so much of the growth of healthcare in the United States.
Yeah, I think we talked about that on the show a number of times too. And so when it comes to the hospitals, again, someone walks in the hospital, they just get their care, they go home. But, people work at the hospital. Explain to most people what the difference is in the hospital governance, right?
Sure.
From a physician standpoint, from a nursing standpoint, from, corporate, and how the, people buy bedpans versus, all that sort of stuff. Kind of just give a general idea of how to run.
So there's really two tracks of governance in any hospital in the United States. One track is the general corporate governance, and that is the bigger picture overall governance of a hospital that is governed by a community board of directors. So, for example, our main hospital, our medical center in Grand Rapids, has a community board of directors that's comprised of, I believe, 11 or 13, I'm forgetting the exact number of community members. And some of those community members are physicians, practicing physicians at the hospital. Mm-hmm. Others are various community leaders, just our neighbors throughout the community who care deeply about how healthcare is delivered in their community. And they are responsible for overseeing, directing management of the hospital. They are careful not to get into the weeds of actually running the place. That's management's job. Mm-hmm. But they are responsible for management of the hospital, but they're also responsible for the quality of care at the hospital. And their main agent for ensuring the quality of care at the hospital leads to the second track of governance in a hospital, and that's the medical staff. And in my introduction about our health system, about Spectrum Health, I neglected to reference another very key component of how we serve our neighbors in West Michigan, and that is the private medical staff, the independent physicians who are actually greater in number than the physicians we employ through the Spectrum Health Medical Group. So and the medical staff really synthesizes the quality of care provided in our hospitals by both the employed physicians and the private practice physicians, because our neighbors really don't care who employs who. No. They just assume that the hospital has figured out how to provide the highest quality, most efficient care to them and their families when they come into the hospital. And that, again, that's accomplished primarily through the hospital's medical staff, mm-hmm. which is governed not only by all members of the medical staff have a vote, but it's governed primarily by the medical executive committee. And the medical executive committee, whenever there is a problem or an issue with care by a physician, and which is fortunately infrequent, but it does happen because physicians and those others who are credentialed on the medical staff, they're humans, and sometimes mistakes are made, and sometimes it's the mistakes are so substantial that the medical staff needs to take action, and the medical staff will take action through a very confidential peer review process, and the physicians who participate in that peer review process are granted immunity by various laws, so that they can feel free to do the right thing with regard to their physician colleague, without fear of personal liability and litigation by the physician who may feel wronged mm-hmm. by that medical staff action. And when there is a medical staff action, then that if it is the something really substantial action that is taken by the medical executive committee, then that actually has to go up to the board of directors or board of trustees of the hospital to take the action of revoking privileges. And there are other various actions that can be taken by medical staffs as well. Sure. Limitation of privileges, requiring proctoring or supervision for a certain amount of time. to make sure that that particular physician comes back into caring for patients in the hospital in the appropriate manner. So it's really a very tightly governed, very detailed analysis and actions that occur both at the medical staff level and then at the hospital board level.
Right. I mean, I guess the impact that you just say, you could sort of say in essence, the hospital staff is the ones who make sure all the equipment, all the supplies, all
hospital
that
management,
right, that that you have what you need, and the medical staff is make sure that it's delivered properly, and then they make recommendations to the hospital, say, hey, it'd be nice if we had X, Y, or Z machine or some new medication, and the hospitals will say, you know what, our focus now, we're going to work on transplants or something. We need to recruit people to do this. This is our new objective from our board, right? That would be sort of a recommendation.
Yeah, I mean, this is our strategic plan, and this is what we need to do to achieve our strategic plan is more along the lines of the hospital board. But then, core to that is the quality of care that is provided by the medical staff, and that medical staff governance is key.
Right. And I mean, I guess my experience with the medical staff generally is that the primarily what you're doing is making sure that whatever care that needs to be provided in the hospital, there's someone to do it, right? We need to make sure we have, speaking as anesthesiologist, make sure we have good epidural coverage for laboring women. So, and it's gotten busier, so you need to have more people there, or you need more support staff in order to get the throughput so we can get all the stuff done that needs to be done. Or there's a new service line that's opened up because maybe there's a new procedure that didn't exist before. Now we have to find a way to make sure it's covered. And so that's the sort of the medical staff issue. And then there's the other part that you're talking about, which is I guess when people don't behave properly, either
disciplinary actions or quality of care actions, right, or competence, clinical competence issues that are identified by the medical staff, which is really, as you're familiar with, the very core to the history of American medicine has been the value of peer review, of peer physicians with expertise reviewing and governing and holding accountable their peer physicians to make sure that the right thing is being done.
Right. And the tricky thing with all of this is as you mentioned briefly, there's the risk of litigation if you did not have some sort of closed system without what's the term where you can gather you can get
peer review privilege.
Yeah, where there's no privileges. So I chair one of the boards for credentialing, which credentialing process essentially just means that you're allowing someone to work within the hospital, right? And there is a level of protection for us making decisions,
correct,
in that process, so that we can act properly. It's just like having a limited liability corporation, right? Where you can't go.
The shareholders or the owners are not personally liable for the action,
right?
But the organization could be, the corporation could
correct,
be, but those, so long as the physicians on the credentialing committee or a professional standards committee, for example, or a peer review committee are acting in good faith and acting within the scope of their duties, then they are generally immune from liability.
Yeah, and so
that they can do the right thing without having to look over their shoulders and wondering whether they're going to get sued by one of their colleagues for doing the right thing.
Yes. Obviously, the human aspect of that is it's a very challenging job in the sense if you have a disciplinary action and it's a colleague you work with or you may be familiar with, you have to discipline them or have some say, you can't speak that way to someone in the operating room or on the floor.
Or you can't throw a scalpel at a colleague. Yeah.
You can't grab someone and shake them. I mean, they're all just about anything you can imagine has happened in some hospital somewhere because we were talking about thousands of individuals who are thousands
humans.
of people. They're interacting with each other.
And they're flawed humans and they make mistakes.
Yeah, and we're working oftentimes in very stressful situations where emotions run high and it's hard to, things happen and doesn't excuse them, but it certainly makes it's a challenging work environment oftentimes. And so let's talk briefly about, so this is how the hospital works. And this is probably the case in most hospitals. I suppose if you are maybe I'm guessing a close system like Mayo may be different in the sense that probably all of those are in one because all the physicians are employed.
Mayo Clinic, for example, is a closed staff model where their clinics are staffed exclusively by physicians employed by the Mayo Clinic.
Right.
So they still have a medical staff because their hospitals are still licensed by the state, still accredited by the federal government, and participate in the Medicare program. So they're still required to have a medical staff, still required to have all of the peer review and credentialing bells and whistles. Mm-hmm. But their lives are simplified a little bit in that their medical staff is fully employed by the Mayo Clinic.
Right.
Same with Cleveland Clinic. I mean, with these these clinic models, which are also nonprofit, tax exempt organizations, very similar to Spectrum Health, except Spectrum Health is much more inclusive of not only the employed medical staff, but also of the private independent medical staff.
Yeah, and I mean, there are certainly advantages, disadvantages to both systems, and that's ones that are obvious, I suppose, and less obvious probably if you dug into a little further. The way I would describe our system is probably more typical, certainly in the country, that most hospitals, outside of a university system, would probably be more of a closed system as well. But these hospitals, the way they're structured and the reason they're the way they are is probably because for historical reasons, right? I mean, it organically sort of became, this seemed to be the way you could get people to work in a hospital. At one time, 100, 200 years ago, there weren't many hospitals. And those that were very much charity, right? Philanthropic institutions, or
they still are
through the well, right? Yes, but I mean, I guess what I mean is they didn't have many resources, and today it's different,
True.
Right? And that's it. So like it was.
Well, it was before the advent of
it was before
employer-sponsored health insurance, for
sure.
example, where you had and before the advent of the Medicare and Medicaid programs, where before you had health insurance and government-sponsored health programs, families paid for health care out of their pockets.
Sure. Or through the church, right?
Or through the church.
Money
right. So a lot of the history of tax-exempt charitable health care is through faith-based organizations. And certainly there's a very strong heritage of charity healthcare through the Christian church, but there's also a very strong heritage of that through Islamic faith traditions. It's been categorized as a moral imperative in Islam that free healthcare is provided to those who need it. So it's really been that tradition of charitable healthcare that the vast majority of hospitals in the United States are tax-exempt nonprofit corporations that are required by federal law to provide charity care, to provide either completely free care to those who can't afford it, or many hospitals have a sliding scale for discounts for those who can't afford care.
Yeah, and so I think it's pretty clear that when you go to most hospitals, they oftentimes have saint in front of their name,
yes.
or Beth Israel, or there's some sort of affiliation with a religious organization. Mm-hmm. Whether those organizations are strongly moving forward their values and ideals at this point, it just depends on sort of the situation, right? Talk a little bit about, you mentioned before how hospitals are getting bigger. They're certainly, some people would just classify it as gobbling up, but certainly they're consolidating. This health system, they're actually systems, right? It's no longer just a hospital in town where you used to have 5 hospitals. Now you have 2 hospitals, and it's a system, and now they've got more integrated care and stuff. That's been a relatively recent phenomenon within the last 30 years or so. It's really, but especially the last decade or two, it's really accelerated. What do you think? You mentioned regulation. Could you specifically mention sort of what you think the primary drivers of that, what part of the regulation is it driving that? Is it all EHR? Because it seems like this has happened before EHR.
No, it's not all. It's certainly not all EHR. So, many of the areas of regulation that are really expensive to comply with are, the Stark Law, the Fraud and Abuse Law. certainly all the coding
So
and
explain
billing.
Stark, because people always throw out Stark, and that's actually named after Congressman Pete Stark,
Pete
I
Stark,
think from
yes.
California. What exactly is Stark law? Because there are always people like worrying, oh, you're violating Stark law. I mean, I always hear that from physicians.
Well, it's actually very easy to violate the Stark law, unfortunately, because it's a strict compliance law. There's very little gray area in the Stark law. Actually, due to recent regulations, there is an increasing amount of gray area. There's some. It's a tiny bit more difficult to violate the Stark law now than it used to be, but the Stark law basically stands for the proposition that a Medicare hospital,
which is most hospitals,
which is
right? Except
most hospitals, cannot bill for a Medicare reimbursed service for a Medicare beneficiary if that service was referred by a physician with whom that hospital has a financial relationship, unless that hospital meets one of many exceptions to the Stark law. So an example is that if a physician employed by a hospital performs a surgery in that hospital, the hospital is not permitted to bill for that surgery to Medicare unless they're very careful about complying with the employment exception to the Stark law. Another example is if a private physician group has a services contract or a coverage agreement with a hospital, and that group refers some imaging, a MRI, to the hospital. The hospital is prohibited from billing for that MRI unless the exception is met, and the exception includes things like making sure that payments for the services being provided by the group are at fair market value.
Okay. Whatever that is.
and are medically necessary, not just, there have been many hospitals, unfortunately, some of these bad apples we talked about at the beginning of the show, where they have made up services to pay referring physicians for. And they've essentially been buying referrals. Yeah. They've been saying, well, we know we really don't need this medical director service, but wink and a nod, we'll pay you $200 an hour to provide 20 hours a month, and we know you're not providing any services because we really don't need those services from you, but keep sending those referrals our way.
And an example of that is, you say someone could be a director of surgery, you already have 2 other directors of surgery, but you want this nurse surgeon to bring all their back cases to you, and so that you would pay that, you're basically paying this person off to bring all their cases,
exactly,
their stuff to you.
And I've been very fortunate never to have worked for, certainly not my current employer, nor any previous clients in my private practice have ever been engaged intentionally in that practice. But there are, you see the headlines out there, you see the court cases out there where folks go down the wrong path and they get into a very difficult situation.
So you could almost describe the Stark law as, in some sense, sort of an anti-kickback law, right? So it's a way of saying if you're a group of, say, urologists, you don't just keep, or a group of a couple, maybe a multi-specialty surgeon group, you're not referring all your patients to the other surgeon just within your group who don't really need, or you just maybe you provide imaging services and you're just getting a bunch of X-rays that are unnecessary, right? That's a violation of the Stark law that you're.
It generally would be, but something very interesting about the Stark law is that it is not intent based. You can violate it without intending to violate it. If a hospital is making payments to a referring physician, and they unintentionally they didn't understand that the amount they were paying that physician was way above fair market value. Well, they did not intentionally pay that physician above fair market value, but it didn't qualify for the Stark exception, so they violated the Stark law, and they would have to pay back all of the amounts they've billed for those prohibited referrals, plus many times damages.
Sure.
In addition to that. Now, the more serious, Stark law violations can get really very expensive, but the more serious, more financially substantial violations for a hospital is something called the anti-kickback statute, or AKS, and that is the intent-based statute, where if the federal government of the federal prosecutor can prove to the court that the hospital actually intended to pay a physician to refer services to their hospital, then the damages and criminal, I mean, that's a criminal law, and the criminal penalties for the hospital, and in many cases under the False Claims Act for hospital executives and for physicians personally, can be hugely substantial.
Yeah, I mean, that's always the fear that people have. I mean, I think you have regulations, and I think people always assume regulations are fairly cut and dry. Like, again, you put poison in something you don't, right? But I think oftentimes there are the gray areas, and maybe gray areas isn't even the wrong term for it, but it's certainly there's interpretations. Maybe is the best way to put it. Like, what is actually allowable, not allowable, and as practices change, and as the industry changes, things that were never imagined by regulators suddenly have to be regulated, and they interpret it the way they, and this can become an expensive legal discussion one way or the other, and you're in the court, right? I mean, or at least you're dealing with regulators. Which reminds me, actually, so do you interact frequently with regulators? I mean, from a regulatory standpoint, from the hospital, what kind of regulators are you dealing with? In the hospital, we always know JACO, or the I think it's
sure. So JACO being the Joint Commission, the accrediting body. Certainly, they will survey us periodically.
They're a private group, just to be clear.
They are a private group.
They're private public. It's kind of hard to describe.
But the federal government relies substantially on the accrediting agencies for certification. Sometimes you'll have the government come in behind a private accrediting group like the Joint Commission to do their own survey, but many times they will rely largely on the Joint Commission for the accreditation. The accreditation is what quality measures are in place to make sure that quality of care is being provided. What is infection control? What safety measures are being taken both for patients and for employees.
Yeah, sure.
So all of the bells and whistles that are important, not only for a care environment to operate, but importantly to the accreditors, for that care environment to operate in a quality, safe way that does not result in patient harm. But as to the true government agencies that we work with on a regular basis, both state and federal, I would say in our acute care environment, primarily federal. So we're very, very careful with our patients' private health information. Their PHI under the HIPAA laws is very closely guarded by us, and occasionally we will have an employee who disregards his or her training and will choose to get into their neighbor's medical record, or an ex-husband's or ex-girlfriend's medical record, and dig around, and we have mechanisms that identify that. If it's over 500 patients who are involved in a breach or a disclosure, then we're in the mode of not only notifying those patients in the disclosure, but also notifying the Office of Civil Rights of the Department of Health and Human Services of that, and then they will launch an investigation. Their investigations can also be launched from the other way by patients who complain that their privacy may have been compromised. So we'll deal also with with the federal government when they have when the Centers for Medicare and Medicare Services have concerns about billing for certain conditions or certain codes, or was it truly medically necessary, et cetera. And because that's really, again, one of the areas of regulation that drives up healthcare costs very substantially, because of the resources that we employ to make sure that we're doing everything we can not to unintentionally violate those regs and those laws. And I mean, it's very easy because these regs and laws are so hyper complex. It's very easy to unintentionally and systemically fall into a violation where the trainers around how to bill a certain code didn't fully understand how to bill that code, and they trained a bunch of providers and a bunch of coders to, this is how you code it, and this is how you bill it, and it is just one smidge off, and because you're just one smidge off of something that a nuclear physicist might not be able to understand, you get caught up in an investigation or a repayment or something that is that's very difficult to navigate. And again, nobody was trying to do anything wrong, but it's because of this very complex labyrinth that our federal and state governments have set up. It's very easy for well-intentioned folks to go down the wrong road.
And this would lead to your initial point, talking about the consolidation, because if you're a small hospital, the regulatory requirements are no different from a large giant hospital versus a small hospital, right? I mean, it's pretty much the same. And so the amount of resource you have to spend is, I mean, it's different because you obviously have a bigger scale. But essentially, you have to have a certain base level of knowledge and
that's exactly right.
And so if you're a small operation like a small hospital, you may not be able to reach that. And so then you look out for someone to provide those services for you, either in the market, but again, there's a price.
It's expensive.
It's expensive, and then or you just say, "Hey, can you come over and we'll just join your organization because it's."
And we've got a department who does this. And,
right.
And we, in many cases, don't have to add extra resources to help them out. Sometimes we do because it's all scalable. I mean, you can only add so many small hospitals to an organization without adding additional legal risk and compliance resources to attend to their needs.
Right. I mean, this is a classic example of regulatory capture, right? That you continually increase regulations for an industry until you pretty much eliminate the opportunity for anyone to enter the market because the barrier is so high. It's hard to come in and actually make
right.
money and get in something. It's sort of classic for any sort of industry as it gets more mature. And then they say, "Oh, we'd love to be regulated." And you see this even for like the social media companies. You're going to start seeing this too from Twitter and Facebook, and as they look to prevent new competitors from coming in and taking their market share by just preventing them from entering. Until someone comes in and they can actually, no matter what they do, they they lose their market. Just like the taxi cabs, right? Forever kept taxis off the roads, but until Uber came along.
Well, and there are still some towns that are trying to keep Uber off the road.
Well, sure,
yeah,
right.
I mean, it's,
so let's change tracks a little bit, because one of the things I want to talk about is, and I want to talk about you. I know you're not an expert on accreditation and credentialing, and I guess based when we talked earlier about medical staff, medical staff have to get credentialed. So the hospital doesn't just let anybody come off the street and say, right. "Hey, I'd like to practice dermatology in your hospital." You're like, "Well, are you trained in dermatology? Do you have what sort of, qualifications? Have you people who say you're a good person, have not, a thief and stuff like that?" And so most hospitals have, well, I think all hospitals have
credentialing
offices.
Right.
They have some sort of process that you go through, and you have to prove your medical degrees or how much experience you have.
Board certification. Most everything, unless your grandfather did, now requires board certification.
Right. And then again, these boards will then meet, or these committees, I guess, and they will decide if you've met the threshold. I mean, it's mostly just paperwork annoyance for most people for credentialing. But there are other individuals who've been to 7 hospitals, and now if you've been to 7 hospitals in 7 years, I mean, are you locum, which is someone who just goes from hospital to hospital to help provide coverage because they don't feel particularly tied to an area and they like going to different places? Or are they at 7 hospitals because they've sort of been kicked out of 7 hospitals, right? And
that's always a red flag when we see somebody. When the royal we, I mean, certainly it's the professionals in our credentialing office. When they see somebody who has been to numerous facilities over a pretty time compressed period, that will raise a lot of red flags, and that draws extra scrutiny. Certainly, technology has actually made our credentialing professionals' jobs much easier now. there are databases, the National Practitioner Data Bank, which all hospitals are required to report to, certainly in more egregious situations when a physician loses his or her privileges, when their privileges are revoked. Well, that always goes not only to the National Practitioner Data Bank, but also to the state licensing authority in that particular state. But there are other privileging actions, different limitations or suspensions, or even a resignation under some type of threat of revocation that are required to be reported. So in the past 15 to 20 years, we've seen a lot of progress in how hospitals are reporting bad actors so that they are not passed around to inflict harm on patients in other facilities. I would not say it's perfect. I mean, I do think there are some hospitals who from time to time, due to fear of litigation, unfortunately don't report what they could or should to the National Practitioner Data Bank or to the state licensing authorities, or when you get pinged by a subsequent hospital to that subsequent hospital, there's a lot of things that subsequent hospital would want to know. At our organization, we're very diligent, very careful about making sure that everything is reported that needs to be reported to prevent future harm. We've seen instances, though. I think, Eric, you've listened to at least a few of the episodes of Dr. Death, which is a podcast I would highly, highly recommend. A terrible example of credentialing gone wrong at a series of Texas hospitals, and this physician was really allowed to do harm to change the lives of many families. Actually, several deaths resulted from this physician's activities that could have been stopped much earlier had the credentialing rigor of his facilities been up to par. And it was really thanks to some heroic activities of two physicians in particular who really put their own careers on the line to make sure that this physician did not harm anybody else, that he was finally removed.
Yeah, I think it's very easy to see how these things happen. I don't like saying it that way, but when you have these, or you have someone who comes into the hospital, let's say it's a new graduate from a residency program, so they have no history, and there's always the understanding that they're going to be slower. They're not going to, and I'm just going to look at it from a surgical perspective because that's where I'm most familiar. But they're not as skilled as someone who's been in practice for 10 to 15 years, and so you have to look at them and say, okay, is this someone who is dangerous? Is this someone who is doing harm because they're reckless, or is this someone who's just learning and practicing, and their errors are ones that are correctable and that are due to inexperience? That makes people kind of scared to hear that people talk about that. But you think about this, if you watch any profession, it's always this way, right? Whatever you do, when you first start doing it, you're more likely to make mistakes or to not be as polished as someone who's been in the career for a while. Whatever it is, whether you're an electrician, whether you're a baseball player, right? The rookies don't play as well as the veterans. And so it's the same in medicine. And then the tricky thing is oftentimes, is this someone, how do you differentiate? And I'm not asking you except to say that it is very difficult to sometimes determine that until you have some experience. And then once you do figure out or have some idea of what you figured out, can you prove that this is a problem? And that is very challenging to someone to say, well, your complication rate exceeds what we expect. I mean, sometimes it's obvious. Some people are just crazy reckless, but sometimes it is hard to know for sure. And then the easy solution oftentimes is, why don't you just not work here anymore? And then
it becomes somebody else's problem.
Exactly. Yeah.
Which is very difficult.
Yeah. And you can the example with Christopher Dunch from Texas we're talking about, Dr. Dunch, it was sort of like one of those things where a bunch of people notice problems, but they're kind of like, it's sometimes hard to sort of prove it. It's confrontation. And so people don't like to confrontation in general. And,
they don't want to get involved.
Well, not only do you want to get involved, but I would argue that, anytime you criticize someone else, well, guess what? I've made mistakes too. And right. So they could just as well come back and say, well, you've made mistakes. Let's have a discussion about you. Right. And so it's just, the human element is always there. And so it's really challenging to do the right thing sometimes, or at least go that far.
I think one key element in all of this is culture, the culture of an organization, and especially the culture of a medical staff.
Yeah.
An organization and the medical staff of that organization can put in place all of the beautiful, elegant procedures and policies that they want, but they will all fail if the culture is not one that values safety, quality, accountability, doing the right thing, and creates a safe environment for all members of the care team to speak up when something isn't going right and when they know something isn't going right. We've seen numerous breakdowns, and not just in healthcare, but in other complex organizations in the past, where it's not that safe culture. Where they've got beautiful policies and procedures, but the culture is such that people don't feel comfortable stepping up to do the right thing. So we've been very intentional, and it's been a journey over the past 17 years. I've been with the organization. I've seen so much progress in making it an open, safe environment for any member of the care team, a nurse especially, to call a timeout, where everybody understands that any member of the care team has the ability, the very welcomed ability, to say, stop, this isn't going right. We didn't go down the checklist. Remember, doctor, let's stop. Let's go down the checklist. I know you don't like the checklist, doctor, but let's go down the checklist to make sure we're not going to do a wrong-sided surgery. Right. Make sure we've got the right knee here. So I think, again, I'm a broken record here, but it comes down to culture.
Yeah. I don't think there's any question about that. And I think when it comes to safety, I think it's important too to note that when it comes to culture and the setting a safety culture, and one in which anyone can speak up, the janitor walks by, sees something that's just not right, like a bunch of sharps sitting out or whatever, or that you have to have a process where there is not really any retribution, right? Like you have to almost have an attitude that mistakes are going to be made all the time, because it's a human institution and there are humans operating or moving parts all the time. And so there are going to be mistakes made, hopefully none of them that are important or that result in any harm to someone or significant problems, but that you have to have where you can report it, and that you encourage reporting, and that there's no actual, that errors are seen more as a process problem than an individual, like right. You're a lousy person. And that is very difficult, because most of the time when in organizations they have, again, whatever policy, procedures, and plans and stuff you have, and you say everyone should report any problems. But if you know that reporting someone who did something wrong is likely to get that person in trouble, or if they're going to some sort of harm to their family or whatever, you're much less likely to speak up about that. Or, certainly if there's retribution towards you, if you're, a lower status in the organization. That's really hard to have a system that really encourages lots of reporting.
It takes a lot of hard work to get to the point of an organization where an organization does not have fear of retribution for doing the right thing.
Yeah, and I think that's probably the hardest thing, right, to have as an organization. And I don't know. I mean, that's one thing I know a lot of hospitals work towards, but it's really hard to implement because you have limited resources in dealing with, I shouldn't say complaints, but dealing with these issues. And so it's almost easier just, okay, this person's had 20, instances of problems. Let's just sit them down and talk to them about it, rather than saying, let's figure out the process of why this keeps happening, Yeah.
And it's, it really, we were talking about, the culture. I was probably focusing too much on the in the moment culture of speaking up when you see something that isn't right and is not going in the right direction for that particular patient. But I believe that having that safe culture and that safety culture and that safe environment where folks feel okay speaking up, I think that bleeds over into feeling safe to speak up when you see a pattern in a particular provider.
That's different.
And that is different.
Yeah.
Because that is, and that's bigger and more substantial, because then you're really talking about impacting somebody's career and somebody's family and somebody's livelihood, and that's higher stakes. But I know that our clinicians, by and large, focus more on the patient and focus more on the harm that needs to be avoided for the patient and for future patients. As difficult as that is, because they have friends and colleagues, most of the folks I work with and I'm familiar with in the clinical setting, as difficult as it is, will put the patient first ahead of a colleague who clearly should not be practicing anymore. And that's, but it's very rare to find a colleague who shouldn't be practicing anymore, because more often than not, it's the colleague who needs to do some things differently and reform some, and a lot of it is actually behavioral.
Yeah,
I mean, there's a lot of disruptive physicians where it's not so much the quality of the clinical care. There's not clinical incompetence, but it's really how they're treating others in the care environment that can lead to problems with their medical staff status. And I said a lot. There actually, fortunately, aren't a lot of those that I'm familiar with, but that comes up. I don't have the statistics right in front of me, but I think it's probably half of the issues that are coming to medical staffs to deal with are more behavioral in nature than they are clinical competence in nature.
I feel that's probably a low number. I think it's more than that. And it's interesting because, I was president of my group for 4 years. And so, again, I was surprised at the level of behavioral issues that you deal with in an organization. People who are intelligent, they're highly successful, and yet incapable of behaving properly in most settings. It doesn't make any sense to me. And then I talk to other people now who are, patients who are managers of a restaurant or whatever. And it's the same thing, right? It's like the number one headache is always the behavioral issues, and people are disruptive. And so medicine's no different, right? It's like, it's the same. I'm sure it's the same within your corporation, in the corporate structure. I mean, it's every large organization has this problem. And that's actually the least fun part of the job, any sort of leadership, is dealing with people who are just unwilling to get along, or who are, for whatever reason, they just don't mesh well with some certain person or with whatever the goals are of your group. Anyway, that was my impression when I was in leadership. But going back a little bit, we talked about the National Practitioner Data Bank, and so this is a place where it houses instances where you've lost, like you mentioned, where you've been suspended from a hospital, and so that if you go and apply for credentialing at a hospital, let's say across the country, that hospital will be able to look in and say, oh, hey, based on your national provider ID number, you've had these actions against you. So then what happens oftentimes in the medical staff office is, so the medical executive has to decide what to do for disciplination or disciplining of a physician or some other person in the hospital. And they will, the thresholds are oftentimes used as sort of guidelines, like, is this so severe that this person should be reported nationally? It's sort of like the scarlet A going to be on their chest for the rest of their career, or are we just going to say this is going to be 1 week? It's interesting how that the National Practitioner Data Bank has in many ways dictated the sort of discipline actions we perform.
But there's really
I'm not saying
there's not a lot of discretion as to what can and can't be reported to the data bank. It's in most cases, it's very clear whether a particular action or a particular event needs to be reported to the data bank. So right. There's not a lot of gray area or leeway there. What I would say then about, once there is a medical staff action or a resignation reported to the data bank, then it's really up to the subsequent hospitals to decide what to do with that with that information. And most of those organizations will understand that they have vulnerability to be engaging in what's called negligent credentialing if they bring somebody on their staff with full knowledge that this person has had past issues. Now, there are some situations where there are explanations for why that data bank information is in there, and through a thorough, way in-depth investigation, the hospital can get comfortable bringing that physician with a data bank reporting into their organization. But I think it's pretty rare that a physician with National Practitioner Data Bank reporting information in any substantial manner on their record is welcomed on to a medical staff of a reputable hospital.
Yeah, it makes it more challenging. And I know that when we've had instances on our credentialing where we have someone who's, I don't want to say suspect, but certainly have maybe something in the past that you're concerned about, you have extra hoops or extra evaluations and people tracking them and making sure that you've at least got keep a closer eye on them than you would the average person, right? I mean, that's
more monitoring. In some cases, proctoring. Many would say, well, if you know you're bringing somebody on right away, they'll need proctoring. Why bring that person on at all? But it's a fact-specific analysis every time.
Yeah, I mean, we have challenges because we do background checks on everybody, and so there are times when people have a DUI or 2 DUIs. Well, what do you do with that? It's hard to know, right? I mean, it was 10, 15 years ago. Well, maybe you don't worry about it.
What if their clinical care is excellent over since then? What if they've turned over a new leaf?
Or what if they just haven't been getting caught, right? I mean, it's hard to know those things. Or one of the local colleges, his class is, if they graduate from one of these local colleges, they almost all have a minor in possession charge. It's like a very common thing. When they're 18 or 19, it's like a money generator for the university. So, I mean, it's hard to know what to do with those things, especially when it's further out. But I think that's the challenge with it. When it comes to someone like Dr. Dench, it's hard to sort of expose this thing. It's hard to oftentimes prove things without great personal risk, or at least collegial risk. And you just have to have a hospital that are willing to, I suppose, support the people who are the whistleblowers, we'll call them, in this situation. But you can see how it happens. Like these things happen where someone is sort of kind of okay. They seem okay, but then their outcomes are not okay, right?
And unfortunately, there have been numerous instances in the past 10, 15 years, less recently, because I think organizations are increasingly more careful. But there have been numerous instances where it's been shown in these high-profile litigation cases that hospital management actively looked the other way.
Right.
Knew what was going on, but this particular surgeon, this particular pain management physician,
sure,
for example, was generating so much revenue for that particular hospital that they looked the other way.
Yeah, right.
And that actually, I mean, not only can that result in huge liability, and should result in huge liability for organizations that actively look the other way from a medical malpractice perspective, but it's also now been identified by the federal government as a potential False Claims Act claim, where if that person is not providing quality care, then the Medicare program says, well, why should we be paying for it then?
Yeah.
So there's all sorts of different hot water folks can get in if they don't pay attention to these folks who are not providing quality care and actually creating unsafe environments for the patient.
Well, I think that's a good summation of sort of thing. Although, actually, one question. I always say I'm done, and I remember that for one more question. I have I've had on in the past, I don't know if you listened to Dr. Houston, she had a credentialing problem, actually, where she was providing emergency work for a hospital and then left the hospital. I think she was doing locum work, if I recall. I'm not sure. I can't remember the specifics. But she left the hospital and she was working in another state. And then she was summoned, that she got in trouble, basically, because the prior hospital continued using her identification as providing care for patients in the emergency room months after she had already left. And so she was left with trying to prove that she wasn't the one who submitted it, because the other hospital was submitting all the bills for her because they were just hired her.
Were they still billing on her?
Yeah,
the previous hospital was still billing on her behalf.
And so it became a big problem to her because she suddenly lost. I mean, she was, from a licensing standpoint, she was practicing with her license. I think in the state of, I can't remember what state she was in. Maybe it was Florida at the time. And so one of her goals is to try and have for physicians to actually control their credentials as opposed to having the hospital. Because right now the hospitals control all the information in the credentialing process, but instead to have the physicians have all that information stored on a blockchain, and that way they have a more secure, I guess they can secure their identity much better, and they, as opposed to letting the hospitals control it. I
have seen a business model out there. It's a startup. I forget the name of the startup, but where they are establishing themselves as a credentialing clearinghouse for all sorts of different types of providers. And I could see that type of organization being really very helpful and being able to catch instances like you just described. But it, unfortunately, it sounds like a situation where that previous hospital didn't do the right thing, either intentionally or unintentionally.
Yeah, I think it was
probably unintentional, but it also seems that CMS could set up some mechanisms for that within their IT systems, where it should be able to flag it. It should be able to catch it where this hospital in this region is billing for the same physician as this hospital in this other region, and they should be able to throw up some red flags, and you shouldn't be able to have the physician being billed for in two separate hospitals in two separate markets. That at some point the computer should spit that out with an audit flag.
And I suppose at some point it did, but it probably took a while, and we always assume these levels of efficiency and detection that just don't exist within, because even like you look at auditing for the IRS, it's very small percentage of people who are actually audited, and so it is very much the honor system that we perform most things. Whether that's even how many meat inspectors are there really in the country? There probably aren't that many, right? But that there's a potential that are going to come by. Most people are doing the right thing anyway, and so it's really not an issue. Same thing with the JACO. With the Joint Commission, when it comes to inspect, we know they can come by any time, but we also know when they're there, right? And they're just not there very often because they can't be everywhere, right? That's the point of regulation. Anyway, when it comes to regulation, it's always tricky as far as how it's actually enforced. So you're not the usual public persona that I have on the show, but is there places do you write much? Do you have, outside of legal opinions that are just within the corporate
When I was
structure?
younger, I wrote a lot more articles. I haven't written an article in a while now, but I am on Twitter at DM Leonard 2001. Although I must admit that I don't tweet very much. Maybe I need to get into that, like the rest of the civilized world.
Is it tough for you to tweet as a corporate attorney? Because you're probably restricted you're probably limited a little bit in what you can sort of comment on, right? Because you're the face of the organization on some level, as opposed to just a private individual.
Which is probably why I don't tweet very much.
Yeah, right, exactly.
No, but I can comment on different areas of public policy, so long as they're consistent with and supportive of my client organization's position, then it's just fine.
Yeah, right. Well, and that's the case for anybody, right? You can't go on bad-mouthing your organization if whatever you might be, because they probably won't like that much either. Well, thanks so much for being on. I appreciate it.
My pleasure. Glad to be here.
Thanks for listening to The Paradox. If you like what the doc is doing, please subscribe and leave a review on iTunes or Stitcher. And share the show with your friends. Become a supporting listener to get access to special bonuses at patreon.com/theparadox. Show notes can be found at theparadox.com.